Hi, well, thanks for joining me. I'm Dr. Tony Capizani. I'm the trauma medical director here at Hillcrest Hospital in Ohio. For the next hour, I wanted to review with you a more focused review on thoracic trauma, spending about 20-25 minutes there, kind of carrying down the body until we get to the trauma of the abdomen, and then completing the talk in discussing extremity trauma. So I don't have any disclosures during this hour talk. Just a little bit about myself. As mentioned, I'm Dr. Tony Capizani. I'm an assistant professor of general surgery and anesthesia at Cleveland Clinic Foundation Lerner College of Medicine. I've been the trauma medical director here at Cleveland Clinic, specifically Hillcrest Hospital, for about 3 years now. Very passionate about trauma care. I've been involved and still am state faculty and a course director for Advanced Trauma Life Support, or ATLS. I'll often be referencing those courses as algorithmic type care have stemmed from that management throughout our country. I'm board certified in both general surgery and surgery critical care. My general surgery training was at Wake Forest University in Winston-Salem, and my surgery critical care training fellowship was at University of Michigan. I'm a proud member of Eastern Association for the Surgery of Trauma, and throughout the talk we'll be referencing a lot of great algorithms that come out of that society and many other trauma societies that give a nice algorithm type approach to a lot of different pathology and trauma. My ICU training and background has been supported by great membership to Society of Critical Care Medicine, and we'll kind of more discuss the more detailed aspects of ongoing thoracic, abdominal care in the ICU, and some of that stemming from my involvement with critical care medicine. And kind of in conclusion, been a fellow of the American College of Surgery, as soon as I can get it. So let's get started. So this 20 minutes is kind of a focused review of thoracic trauma, understanding that thoracic trauma is the second most common injury in trauma patients in our population. The most common being, well, it's kind of tricky, polytrauma actually. So patients that suffering a lot of trauma in many very different anatomic locations, followed by head injuries, isolated chest trauma, abdominal trauma, and extremity trauma. For the most part, blunt thoracic trauma distribution, clearly a lot of it involves the chest wall, the lungs, cardiac, diaphragm, esophagus, aorta, and more of the rare injuries in the tracheobronchial tree. As mentioned, it's the second most common injury in trauma patient. It does increase the risk of death with as we get older, as we have more ribs involved in the trauma, any associated comorbidities like congestive heart failure, or ongoing care in the ICU and ventilator-acquired pneumonia. Most of our blunt trauma accidents is from motor vehicle collisions, about 75% of the cases. There's both direct and indirect type impact with our injuries to the thoracic cavity. The direct impact having sequelae of rib fractures, pulmonary contusions, sternal fractures, the scapular fracture, various kind of bony type injuries. Whereas indirect, that's more from that acceleration, deceleration mechanism, whether it be a motor vehicle accident or motorcycle accident. These can really result from anatomical locations, from pulmonary laceration where the bronchioles are fixated in certain spots and not others. There's a pulmonary contusion on the microscopic levels and in the capillaries, and then even on a tracheobronchial disruption with almost 100% mortality. Kind of diving into the thoracic trauma and how we're going to divide up this talk, go over some brief anatomy, kind of cover the more common injuries that you would anticipate to find, complications that are associated with that, and the overall management of the type of care. So first, let's focus on the anatomy. Now, thoracic anatomy, don't forget, as I know you wouldn't, is it still does involve the back, not just the front aspect of anatomical locations, from the very top down to the bottom of the rib cage and laterally. And a lot of chest trauma does just involve the chest wall and the involvement of the bony ribs and cartilaginous attachments. Again, that chest wall that we start to get into more involved in penetrating trauma, we like to focus as depicted here in that peristernal area and that area in between the scapulas that leads itself to more cardiac type injuries when we're dealing with penetrating trauma. kind of deeper aspect into the chest, the 3 lobes of the right lung versus the 2 lobes of the left, and the associated bronchi and the attachments, things that can lend itself to more devastating type acceleration, deacceleration injury. More prone injury is just based on anatomy, right? So your right atrium and your right ventricle is the more anterior aspect of the cardiac involvement, especially given motor vehicle accidents and that kind of penetrating injury in that peristernal area. Understand that the great vessels tend to be more involved, or can be more involved, from a posterior aspect and penetrating injury to the back, as well as your left atrium and left ventricle. Left atrial injuries being less often found in blunt injury, but more or less having a right atrial type injury in blunt mechanisms. Again, there's those significant attachments of the aorta, that blunt injury and aortic involvement, and a lot of that has to do with its kind of congenital attachments and areas that aren't as attached. The cardiac, obviously, window, as I mentioned, in that pericardial window, or really that peristernal area, as far as that window of injury from a penetrating standpoint, and things that can be injured from that aspect. From a thoracic type injury, we can also have, as mentioned, blunt thoracic injury and penetrating thoracic injury and trauma. Let's first go over some of the more blunt thoracic trauma and things that we can find from those type of injuries. The injury pattern that we often see in blunt thoracic trauma is more commonly your rib fractures, your flail chest, and the flail chest typically only happening in that kind of 4 to 8 rib zone. Pulmonary injuries of various type, whether it be contusions or lacerations, cardiac contusions from blunt injury, pneumothorax, hemothorax, and blunt aortic injury. And one that can more rarely found is even your diaphragmatic injury. As far as the rib fractures, the posterior ribs can be difficult to see on X-ray, but can often be missed on injury. 4 to 8 commonly associated rib fractures can be associated with the flail chest. Even ribs 8 through 11 have a sign of potential intra-abdominal injury. The elderly are more particularly susceptible, and we know that mortality really rises as we get older, and especially as we have 3 or more rib fractures. And then, associated flail chest. So if those 4 to 8 ribs, or numbers 4 to 8 ribs, are injured and causing a flail chest, it's not just so much for the paradoxical movement as it can have primary pulmonary dysfunction because there's an underlying pulmonary contusion. That's how significant the mechanism was. And then, of course, you have that paradoxical movement now not allowing that flail section to really expand. Understand that beyond that rare event of retroperitoneal attached structures in the thoracic cavity, the very rare mechanism of tracheobronchial injury, most of those patients don't even make it to the hospital. But those that do would require an emergent airway, whether it be intubation or surgical airway, as mentioned in the previous talk. Be aware that there's often associated hematomas that can be associated with that. And again, as all trauma patients, they can have an associated cervical spine injury. Those kind of patients that are afflicted with the tracheobronchial injury, video laryngoscopy can be helpful, as well as direct laryngoscopy. Mucosal tears can be closed, or even a more endobronchial type stent can be used in really treating those injuries. Always, when you have a tracheobronchial injury, to perform a tracheostomy 1 ring below that rare type of injury, and then having ECMO or cardiac bypass, I think, is paramount if you're going to be able to handle these type of injuries. Pulmonary type contusions is a far more common injury, much more common than tracheobronchial injury. And these you can see on plain radiograph, as well as CT scan. Again, these are not infiltrates related to aspiration, and they don't have that kind of geographic association that an aspiration event might have with the right middle lobe. But you would see contusions kind of crossing lung markings, more specifically crossing into other lobes. On chest CT, pulmonary contusion don't have that classic dependent pattern, but can at least blossom out as the patient continues on in their ICU care. Which reminds me, that type of care for pulmonary contusion really is just supportive ICU care. You might often offer a bronchoscopy for any type of obstructed situation, but more or less it's trying to prevent any secondary injury, giving that patient low tidal volume and high PEEP therapy for a pulmonary contusion. What are some more of the life-threatening injuries that are immediate that we see in our emergency trauma bay when it comes to thoracic injury? Well, one of them would be the pneumothorax. So recognizing that this should be a clinical diagnosis, especially when it comes to a tension pneumothorax. Physical exam when it comes to that tension pneumothorax could be absent breath sounds, of course, on that afflicted side, like you see here on the right. But again, look at that massive tracheal deviation that's seen on that radiograph in the right lower hand quadrant of the screen there. Again, you'd have hypotension and JVD. Management, our EMS colleagues in the field are often given the arsenal of needle decompression, and that allows for immediate decompression of that tension pneumothorax. That definitive care of that pneumothorax or tension pneumothorax, of course, is going to be that thoracostomy tube or chest tube that you're going to apply and insert in the emergency department. Kind of similar pathology as far as physical exam findings would be a thoracic trauma when we talk about cardiac tamponade or a cardiac blunt type injury. Just like a tension pneumothorax, you're going to have distended jugular veins. Patient can also be hypotensive. And some of that, what we're finding is on fast scan that we're breaking out very early in our primary survey and our assessment, we'll see a pericardial effusion associated with that cardiac tamponade. Other things that we're going to see associated is even though we have that fast scan very easily available, is don't forget about the physical exam, of course, right? And what are we going to find in that physical exam? Well, some pulsus paradoxus and kind of the classic, Beck's triad. Well, what are those? So, pulsus paradoxus, we're going to have an abnormally large decrease in your systolic blood pressure and a pulse wave amplitude during inspiration, whereas normal fall in pressure is only about 10 millimeters of mercury. Within classic Beck's triad, that consists more of venous pressure elevation or JVD, right? So the heart can't fill because it's constricted. You're often going to have, because of that, a decline in your arterial pressure. And then if you have the luxury of a quiet trauma bay or trauma EMS squad, which we don't often, but you would hear muffled heart sounds. So how is that seen in a pictorial aspect? Well, this next slide kind of demonstrates that. So kind of walking you through this slide here, we're looking at both A and B. So A, kind of measuring that pulsus paradoxus and what's happening as the systolic pressure is dropping and your diastolic pressure is rising. And you see there depicted in the middle screen that pulsus paradoxus kind of row and how they're susceptible to different muffled heart sounds. Again, what you're going to experiencing during inspiratory mode, right? That drastic drop in arterial blood pressure tracing. And that's depicted by the row there that's simply labeled arterial pressure tracing. But it's concomitant with that intrathoracic pressure seen both on the inspiratory and expiratory phase as far as expiration and what happens with cardiac tamponade, and more importantly, that ventricular interdependence with that. Again, you have that significant fluid buildup around the heart, and you can see by the schematics on the very bottom of that picture of the ventricles not being able to be filled like you see there in normal expiration in a normal heart, where the heart has adequate filling and preload dependent and fills very easily. Offering from a therapeutic standpoint from cardiac tamponade, in trauma, this does include pericardial window, but you have to ongoing and offer additional therapy for fixing whatever has been damaged from a cardiac standpoint. That often requires a left thoracotomy or even median sternotomy. Pericardiocentesis, although taught, and I think is a valuable tool to have when it comes to trauma care, that's only a drain aspect and maybe diagnostic, but it does offer maybe at least release of that increased venous pressure and allows the heart to fill. But again, it's not addressing what caused the problem initially. Another kind of zebra of thoracic trauma care, but something that we've really developed as far as wonderful care over the years of thoracic trauma type care, is your blunt aortic injury. A lot of it comes from the mechanism alone in the history. There's that rapid deceleration injury, and that leads to potential mobile portions of the aorta and tears. Things that you're going to find on physical exam, if they make it to your hospital, most of them could pass away in the field if it's a severe disruption, but those that do might have stable systemic hemodynamics, that they could have lower or at least maybe no blood pressure in the lower limbs. Some more common radiographic findings that we can have to help diagnose that. on chest x-ray is what you might see here in the bottom right-hand corner radiograph depicted. So the most common radiographic findings are what's seen here. So your widened mediastinum and your indistinct or kind of blunted aortic knob. Up to 10% actually, though, can have a negative chest x-ray. So how are we going to follow up on that? Well, there's other things that we can find with an aortic type injury. So aortic injuries can be associated with the first and second ribs that are fractured, and that really lends its hand to understanding that there's a significant mechanism of acceleration and deacceleration, or even impact, to break those top ribs of the thoracic cavity, but also be associated with an aortic injury. Of course, with aortic injury intimately attached to the heart, so you have associated cardiac injury, and that seatbelt type sign and injury from a lumbar spine association. What's developed over the years, and a lot of this come out of Memphis and a lot of wonderful trauma care level 1 facilities, is that how to identify these type injuries. So although the TEE you'd think, because it's close to the heart, has a better imaging modality and diagnostic capability, not so true in trauma. So it's been identified that CT scan aortograms are more sensitive in identifying aortic blunt type injuries. The CT scan is depicted in the top right-hand corner there, and the identifying arrow of that kind of almost figure of 8 type picture of the descending aorta. The other aspect that's very obvious in that arteriogram or aortogram is the kind of outpouching of the aorta, or that contained hematoma, rather, of the descending aorta in that arteriogram. How to kind of manage these injuries? We want to take a little deeper dive into that because the history has changed quite a bit. Not so much more clamping and sewing anymore, as we're making sure we're having those patients on bypass. And what does that prevent? Well, you can see that the clamp and sew versus bypass can have a very similar outcomes, but one thing that's changed drastically is you can see that paraplegia percentage can differ drastically between the two aspects of care. Specifically, when you bypass, you have a much smaller paraplegia rate. Other things that's really advanced over the years is endovascular stent capabilities. And this has helped really reduce the intraoperative complications, specifically even mortality, and the overall mortality. It's far less morbid procedure. It does require kind of high tertiary, quaternary type care institutions, but it's offered a really wonderful care for these rare injuries that can be managed on an elective setting and not crashing into the operating room, but really treating that patient with beta blockade, good ICU care, preventing secondary injury, and then approaching the injuries from an endovascular standpoint. So what about that exciting penetrating talk that you're wanting to listen to on chest trauma? Well, this is a good portion of thoracic trauma and the involvement. So 40% of penetrating injuries do involve the thoracic cavity. Not as much as requiring ED thoracotomy as once was, maybe. 15 to 30% of penetrating chest injuries that are requiring thoracotomy. And overall, penetrating injury to the chest cavity may be encompassing up to 13% of trauma admissions in the United States. Kind of the penetrating organ distribution. Well, if it's penetrating the chest cavity, it's going through the chest wall. So 100% there. But also associated injuries as far as lung, cardiac, and diaphragm. But we're getting down to even that abdominal area, right? So you're getting down to the lower rib cavity, the lower rib cage, and you have associated almost 20% liver injury with this penetrating type mechanism. Overall, that penetrating thoracic trauma, you're going to need to make sure that the patient's stable from an A, B, and C standpoint, understand what the mechanism is, typically gunshot or knife stab wound, and of course that anatomical location. Luckily for this victim, noticed here, these are all tattoos. Otherwise, I don't think he'd be standing straight up. But again, understanding that there's peristernal areas and in between the scapulas that really can be that life-threatening box of penetrating injury when it comes to thoracic injuries. Even approaching every penetrating trauma patient the same is going to be important. So demonstrating that your patient has stability, getting to the A, B's, and C's of initial resuscitation and hemodynamic type care. The trajectory might be a little bit more predictable when it comes to knife injury, but overall understanding the mechanism and really appreciating the history of what's involved. How many gunshots were heard? How many do you see? How many bullet holes do you have in your patient that you're treating? And most importantly, the anatomical location of those. So that peristernal area between the nipples and above the epigastric region, high likelihood, and kind of peak your ears up for potentially a cardiac injury. Just the same on the back too. So if it's in between the scapulomedial borders, high likelihood of having great vessel injury or cardiac injury. The ones that are dreadful to manage and really kind of work through that algorithm is the transmediastinal type injuries in the chest. Those that require, in your stable patient, if possible, ability to manage great vessels and diagnose that with a CTA or aortogram. Also to see if your esophagus is involved with an EGD or contrast swallow study. And of course, thirdly, following up on your airway and distal airway with bronchoscopy. As mentioned, as a kind of proud course director for ATLS and a lot of different trauma societies, there's a lot of algorithms of care, out there on different societies. This one's actually from our colleagues in Western Association of Trauma, and a lot of critical decisions that are needed. This one tends to look at, is your patient stable or unstable? Immediately by the B, letter B that you see there, unstable is off to a different algorithm. Penetrating thoracic trauma, when it comes to a stable patient, that initial assessment and then breaking down into that incredible tree of care, whether it goes from pneumothorax over to the right hand of the screen to hemothorax, and kind of delineating down to what additional injuries are going to need to be evaluated and what needs to be treated. So a lot of polytrauma just within the thoracic cavity. Like all kind of traumatic injuries, all these, depending on our care, the mechanism, the involvement of the patient, there's associated complications. The complications are numerous. Some of the ones that are common are lung abscesses, bronchopleural fistula, and pneumonia. For kind of the concise aspect of this talk, I was just going to focus on empyema, and that's kind of what we're going to kind of control over at least the course of the conference and discussion today. So empyema has about an incidence of about 5% after chest trauma, whether it be blunt or penetrating mechanism. It can occur after pneumothorax or hemothorax, and a lot of risk factors that are associated with that. The ones that tend to be more common, if the patient has an associated hemothorax and not just a pneumothorax. One of the things that's a risk for that empyema developing, those inadequately drained or retained hemothoraces that bug all of us in trauma care. You put in that nice chest tube or offer that definitive care, and lo and behold, the patient has a retained hemothorax. There's a lot of algorithms out there on how to manage that, whether it be an additional chest tube or VATS, but those need to be definitive care to kind of hopefully avoid that empyema. Other things that make that risk for empyema is associated pulmonary contusions and even pneumonia over the time of the patient's development and within their progress in the ICU or up on the regular nursing floor. Therapy options for this, thoracostomy tube drainage, if it's simple empyema, that would be wonderful to get by with. But a lot of these do require more advanced type care as depicted in the lower right-hand column or screen, depicting empyema treatment with debridement, video assisted, or even some more involved requiring thoracotomy with decortication. As far as the emergency management and the initial management of our thoracic trauma patients, some of this dictated based on penetrating or blunt type injury. Focusing more on the penetrating type injury, there's going to be certain types of incisions that you'll use for penetrating thoracic injury, really based on location. And I don't want to take a too deep dive into this, but just understand that a left thoracotomy can really gain you great access to cardiac injury, of course, left-sided injury of the chest. Median sternotomy or clamshell might get you all the way across the chest and really helping you extend it up into the neck if there's concomitant neck injury. For the most part, penetrating neck injury, you really need good indications for proceeding with that ED thoracotomy or thoracotomy in the operating room. A lot of penetrating thoracic trauma comes with hopefully witnessed cardiac activity or pre-hospital cardiac activity before you're proceeding with that thoracotomy, and unresponsive hypotension even despite a vigorous resuscitation. There's more kind of dictated indications. If you all remember, this was a patient, I say everyone, at least in the United States, might remember that this was a 40-year-old man that had a penetrating injury and actually had witnessed cardiac activity, right? So in this little dictum, you see him, he's been shot, and he sees falls to the floor. And this is when the police are summoned to come to this patient's aid. Now I'll get back to this little vignette on why Some of the indications of thoracotomy were right here, and some of them might have been contraindication. For the most part, ED thoracotomy, it's kind of a damage control surgery. You need to stop the bleeding first. Kind of the paramount of that surgery is releasing cardiac tamponade, cardiac massage and defibrillation if you have that capabilities, and then knowing the anatomical aspects of cross-clamping the aorta and repairing cardiac and pulmonary type injuries. So is this patient going to be a victim, or can he have an ED thoracotomy? Well, time has got to be on your side as the provider and obviously on the patient's side as a victim. So in this particular instance, this patient had minutes and was only minutes away from a nearby hospital. This was the typical load into the squad car by officers, not even by ambulance, and taken immediately to the hospital. Had this patient had a blunt indication, or a blunt injury rather, the indications for thoracotomy are much less. So you need to have previously witnessed cardiac activity, obviously, kind of rapid hemorrhaging from a chest tube. A really unresponsive patient might be indications for that ED thoracotomy in a blunt situation. But again, time is crucial. So when that patient arrives to the ED hospital or the emergency room, and this more famous patient, when they arrived to Roosevelt Hospital, there was only minutes to spare. He had no pulse, he was not breathing, multiple caregivers at the bedside with almost 10 to 15 minutes of desperate attempts to resuscitate him. So ongoing resuscitation without being revitalized. Unfortunately, this patient, John Lennon, if that was approaching anyone's kind of mind at this point, didn't make it. Kind of looking into the details of this and multiple other thoracotomies that we do throughout the country, we've learned that there's certain indications that are pretty hard, fast, and true, and other ones that have some contraindications. Kind of the indications that they involve American College of Surgery and Committee on Trauma. Again, they have that precordial wound in a patient with pre-hospital cardiac arrest that we've already noted to. They've had a trauma patient with cardiac arrest after arrival to the emergency department, and again, during resuscitation, profound hypotension. Why I wanted to mention the John Lennon situation is there's definitely contraindications, at least in the civilian world. They might be a little bit different from the military aspect. But in the last 10 years, a lot of studies have come out for when is an ED thoracotomy indicated and when is it not. So some of the more obvious ones that when it's not indicated, when there's contraindications, the time frame is challenging, but when blunt trauma, when 10 minutes of pre-hospital cardiopulmonary resuscitation has occurred with no response. From a penetrating aspect, if they have pre-hospital CPR for almost 15 minutes with no response. And even that's somewhat fallen out of favor. Asystole with cardiac tamponade. Other things that can also, if you have a known head injury with thoracic penetrating injury, that's going to be your contraindication. And it even gets into further in the literature about pupil response and neurological activity. So there's more and more in looking to your hospital resources and what the resources are in providing adequate ED thoracotomy and resuscitation. Overall, you're still going to provide the A, B's, and C's of types of care for that type of injury. Lots of suction available and cell saver if possible. That anterior lateral approach is going to be key. The rib space is not as important when kind of getting into the chest, but again, to that sharp incision into the thoracic cavity, really getting into the pericardium and avoiding any kind of secondary injury to coronaries. If you can clamp the aorta, that would be ideal, and that's going to reperfuse the heart and offer cerebral perfusion as well. You need to do maneuvers like retracting the lung superiorly and mediastinal pleural dissection, although bluntly, and just be careful of ongoing secondary type hemorrhage. And again, understanding that the aorta is anterior to the spine. If your anesthesia or ED colleague can offer an NG tube or OG to the patient, that's going to allow you to at least more palpate the aorta, because when the patient's hemorrhaging, that aorta is going to be decompressed and unbelievably difficult to palpate. Cardiac repair is going to be important in those patients, large wounds. And this is hopefully when you're getting that patient to the operating room, going to use non-absorbable sutures such as Proline, avoiding coronaries, and this is better accomplished with mattress type sutures. But even on atrial type injuries, those can often be used with an endovascular stapling device to kind of help with quick repairs. As far as the ongoing details, again, the A, B's, and C's, lots of suction, cardiac massage. I want to mention cardiac massage to make sure you use that two-handed technique, and that's so your thumbs don't poke a hole in the ventricle. That can happen. That cardiac volume is really decompressed and it's vulnerable. You're going to have better better perfusion with that standard technique of 2 hands, and you're going to have, hopefully some intracardiac CPR within a 20-minute time frame. Kind of some extras or some pearls of an ED thoracotomy, defibrillation and intracardiac epinephrine might be adjuncts to use during your ED thoracotomy. Really got to stop that hemorrhaging first before you start that resuscitation, or at least simultaneously. Right atrium cannulation is fantastic for intracardiac and actually systemic resuscitation with blood products. You should definitely consider some inotropic support as needed. Bleeding vasculature, you can additionally clamp and eventually suture. Sometimes even clamping the pulmonary hilum if there's devastating type pulmonary injuries. Going on to type of the pearls, survival is highest, again, when there's a single stab or single gunshot wound. Multiple penetrating type injuries, like in John Lennon's situation with multiple gunshot wounds, that was probably a setup for failure and just didn't have a high survivability rate. Overall, if you're going to do that ED thoracotomy and even into the operating room, have your anesthesia colleagues and place that right mainstem intubation. That's good for airway control, but also helps decompress that left chest and get the lung out of your way. The incision is not just about the rib, but within the fourth intercostal space and preferred. Massive transfusion protocol at your institution probably can vary from institution to institution, but when you have a potential for an ED thoracotomy, you should start that on the front end even before the patient's arrived at your institution. Again, as already mentioned, it's contraindicated for a known head injury, or the other thing to kind of be concerned about, if you have multiple cardiac or great vessel gunshot wounds, the ED thoracotomy and resuscitative efforts should probably be terminated when you can identify that from an ED thoracotomy standpoint. Complications, probably the most common is just lack of perfusion, right? Your anoxic brain injury, coronary vessel injury from an iatrogenic standpoint, as well as abdominal and spine ischemic standpoint if you're having to clamp the aorta, an undiagnosed esophageal injury, internal mammary arteries, especially if you're having to come across the chest in the clamshell type technique. And then, of course, the intercostal bundle injury when you're getting into the chest. And again, probably the time and time again is to make sure your colleagues and you are using universal precautions to protect against bloodborne pathogens. Like in that thoracic trauma, it's going to be important to have that knowledge of thoracic anatomy, not just for penetrating injury, but also for blunt injury. It's just going to be paramount when you're approaching what's possibly injured in that thoracic space. The mechanism of thoracic injury often dictates the injury pattern and plan of care, not to mention the length of time the patient's receiving resuscitation in the field, and even signs of life in the emergency room when it comes to ED thoracotomy. Really, that therapy revolves around the patient being stable from a hemodynamic standpoint, and then kind of deciding and dictating where that patient's care needs to continue, whether it be in the operating room or in the ICU, and various modalities of tests that needed to help determine what the interthoracic injury is. So that's kind of the focused review of thoracic trauma. Now let's kind of continue down the body in a secondary survey type fashion, and we'll go on to abdominal trauma. So the next 20 minutes or 15 minutes, let's focus on various aspects of abdominal trauma. Again, as all trauma care, it's going to start with the initial assessment, the A, B's, and C's of trauma care: airway, breathing, circulation, and then going on to understanding what can happen intra-abdominal as far as injuries, as far as vascular injuries, common solid organ injuries that we see, hollow viscous injuries, special considerations, and of course how to manage all these in a very algorithmic type approach. The initial assessment on trauma when it comes to the abdomen, again, get that history, that mechanism, a good physical exam, and is your patient stable or unstable? Nothing's going to beat that history and physical exam as far as that appropriate care. Is it a penetrating wound? Do they have seatbelt marks? Is there identifiable rib fractures, lab adjuncts that you can use? One thing that we commonly use on a blunt abdominal trauma is your FAST scan. So you have your exam already on the patient, and your FAST scan or your focus assessment with sonography for trauma is going to allow you to visualize solid organ injury and potentially free fluid to kind of move along in the abdominal trauma care. The various aspects of the FAST scan is looking for that free fluid. This is the subxiphoid view. And again, that heart border, from in between the nipples down to the epigastric area. So is there a concomitant cardiac injury? And we can determine that by fast scan, by looking at the pericardial fluid. Is there cardiac tamponade even from a blunt trauma mechanism? Moving the probe over to the right side in the right upper quadrant, we're going to look for free fluid as depicted by that black stripe between the hepatorenal fossa. And that's going to help determine if there's free fluid in the abdomen on that right side from a fast scan standpoint. Fast scan is also, of course, used in the left upper quadrant and identifying splenic injury, but more or less perisplenic fluid, and is there evidence of solid organ injury on that standpoint. On all of these views, whether the left upper quadrant, right upper quadrant, or here as depicted in the pelvis, if there's free fluid, that's going to be some indication based on hemodynamic stability of your patient, are you proceeding to the operating room or not. Again, it's not to really fast forward past the physical exam, because there are physical exam findings, of course, in abdominal trauma that will dictate operative or non-operative care. Even with the seatbelt sign that's seen obviously on the picture here, peritonitis is going to be difficult to examine on this patient once they're intubated. So do you have the luxury of a good physical exam before the patient's intubated and a definitive airway is offered to find out if they have peritonitis or severe tenderness? Do they have distension? Are there obvious signs of bleeding, even from abdominal trauma or penetrating trauma, of course? Once you get into the more hemodynamically stable patient, the fast scan, yet it helps you demonstrate free fluid in the abdomen. On a hemodynamically stable patient in abdominal trauma, you have the ability to proceed on with a CT scan. And that's going to be more sensitive as far as other injuries, and definitely more specific as other injuries are associated with abdominal trauma. So within that CT scan, it's going to have a rapid assessment of your viscera, and something that fast scan can't really better assess is a CT scan is going to have a better assessment of any retroperitoneal injuries and abdominal wall injuries. One ideal aspect of the CT scan that we always get with IV contrast, unless the patient has significant kidney chronic disease or known disease, is that it's going to demonstrate active hemorrhage, that blush, that extravasation that's seen on an IV contrasted scan. Also, it's going to help you determine if there's intestinal injury or mesenteric injury, something that's challenging with the fast scan or almost impossible to see. One thing that we can have in abdominal trauma, though, of course, is more life-threatening injuries, and that's some life-threatening injuries associated with vascular type injuries. These come with significant mortality when it comes to abdominal trauma, both the aorta, SMA, iliac injuries, all these come with very high significant mortality and morbidity. The dictum of trauma care still stands, though, and that's hemorrhagic control. When you're in the operating room, it's commonly determined to pack off those 4 quadrants, kind of really determine if you have ongoing hemorrhage from any of those quadrants or anatomic locations. If that fails you, you have a backup, at least a backup plan of aortic control. One of the better spots to achieve that for abdominal exposure is in that supraciliac region when you're mobilizing the left lobe of the liver, vertically dissecting into the gastrohepatic ligament and retracting the stomach and esophagus over. Often you can have an additional hands in the operating room, hopefully with you at that point. That's simply a sponge stick on the aorta with aggressive compression. Not only will allow your anesthesia colleagues to come up and meet you with resuscitation from a cerebral and cardiac standpoint, but it also hopes to allow to have hemorrhagic control in the abdomen. As far as abdominal vasculature in civilian or military type environments, it actually differs a little bit. So in trauma civilian literature, we can have almost 30% of all cardiovascular injuries occur in the abdomen. But this is much lower in the military type trauma, for example, where a lot of the vascular type trauma happens in the extremities. Most of these in civilian literature comes from motor vehicle accidents, a good portion of them from that rapid deceleration or acceleration type mechanisms, commonly associated with a seatbelt type injury. These injuries can have avulsion of small branches of major vessels within the abdomen, even have some intimal tears and secondary thrombosis in the lumen. One of the more common findings would be in the renal artery, or even a direct blow by seatbelt causing a more exposed vessel like the renal vasculature or SMA or SMV disruption. Now, this is all blunt trauma, so comparing it to penetrating abdominal trauma, that offers a much higher variety of pathology. So let's kind of get diving into some of the more abdominal vasculature and what to do. Let's come with different zones. So seen by this kind of picture off to the right of the screen, breaks the abdominal cavity into 3 zones. Zone 1 being the central cavity, where your IVC and your patient's aorta is at, zone 2, where the more renal vasculature is at, and zone 3. Which ones are you going to explore? Well, typically all zone 1 injuries. From a penetrating aspect, you're going to explore the ones in zone 2, and then if they have a blunt aspect, blunt mechanism, you're going to explore those zone 2 type injuries. Really, from the penetrating aspect in zone 3, those will be the ones that you might explore, but very rarely in a blunt mechanism are you going to explore zone 3 type retroperitoneal hematomas. Kind of explained differently as far as a picture. This is more of an algorithmic type care produced by Dr. Maddox and colleagues, again demonstrating zone 1, 2, and 3 type care in a blunt type mechanism. Penetrating injury kind of makes it easier, right? You see something expanding, you see a hole in a vessel, you're going to go after it. But from a blunt mechanism, unless you have a really expanding hematoma in zone 2 or zone 3, you're not going to really treat that operatively, and you're not going to open that hematoma. Now, wait a minute. How are we going to get to these zones, and how are we going to provide therapy? There's various operative maneuvers in the abdomen. One of the more common ones to at least get to the aorta and the viscera behind is the left medial visceral rotation. This is when you're kind of starting low, as depicted here in the picture off to the bottom right hand of the screen, kind of starting with that left lateral colon mobilization and moving from an inferior aspect up laterally and really mobilizing that colon over to the medial aspect and really up to midline, kind of sweeping it over. As you can see here, offers exquisite exposure of the aorta, especially if need clamping and repair, and any potential abdominal aortic type injuries. Other additional abdominal maneuvers that are important in the operative field is a Coker maneuver, and that's more on the right side, where you're lifting up and gently dissecting the retroperitoneal attachments of the duodenum, immediately rotating that, and it allows you a good exposure of the head of the pancreas, duodenum, and IVC. Kind of continuing a more detailed or at least further exposure is when you have that Cattell-Brash type maneuver where you're mobilizing the right colon and hepatic flexure, again, over medially. This gives you great control and exposure of both the IVC and aorta, and as you really retract the viscera medial and downward, kind of completing that Coker maneuver as well. As far as hemorrhagic control, those are great maneuvers as far as exposing potential zone 1 type injuries. But as far as hemorrhagic control, especially when it comes to solid organ injuries, things that should be reviewed is maneuvers like the Pringle maneuver, understanding that the vasculature kind of rides in that portal triad within the hepatoduodenal ligament. If you have ongoing hemorrhage even after control with the Pringle maneuver, you might have more exotic or more challenging type injuries to repair, like a right or left hepatic vein, or God forbid, a retrohepatic IVC injury. The more common solid organ injuries that are typically found in trauma, we have probably the most common being a splenic type injury. And these can be graded. It's probably the most significant and most frequently found solid organ injury in blunt abdominal trauma, almost to 45% of the time. Most of these can be managed non-operatively now, especially when you're dealing with grades, when you have less than kind of 3 centimeters of injury. Anything from a capsule type injury up to that 3 centimeter injury can typically be managed non-operatively. When you start getting into the higher grades of splenic injury, those tend to need, whether it be splenectomy or even spleen salvaging maneuvers like splenic artery embolization. A lot of blood product resuscitation might require more operative care, even if the patient is stable, and understanding that definitive care for splenic injuries requires vaccinations, as depicted here. Other solid organs that are injuries, you have hepatic injuries, the second most frequently injured solid organ. Transaminases are exquisitely sensitive in identifying this type of injury. And of course, we rely heavily on CT grading and types of images, if you see in the bottom right-hand corner of hepatic type injuries. These are more decided upon as far as operative and non-operative care, as far as their hemodynamic stability, their blood product requirement, and again, if hepatic artery embolization can be deployed. Renal injuries might be a little bit less significantly found or commonly found. Again, heavily relying on CTA and even portal venous phase of the CT scan to help determine is there extravasation within the renal parenchyma, also as far as urinary extravasation as well with associated ureteral type injuries, and maybe even adrenal type injuries on those CT scans. again, every solid organ has its own grading system, and that kind of helps determine and kind of a common verbiage of how severe the injury is, and kind of usually what dictates as far as operative or non-operative care. A frequently missed organ on solid organ injury in the abdomen is the pancreatic injury. Usually has subtle findings on that initial CT scan. Can be more common in your pediatric population. Again, repeat CT scans, more importantly on the adult population, might help discern is there a parenchymal disruption as depicted in the CT scan here, nearly at the tail of the pancreas on that CT scan. Pancreas injuries can require a pretty detailed algorithm of care, whether it be CTA, but more importantly, MRCP and ERCP come into really good play as far as its management, especially when it comes to minor or really small pancreatic fistulas that can be managed with stent placement with ERCP. When there's obviously massive disruption, those patients need to have wide drainage, potentially even a Whipple type salvaging maneuver of pancreas type injuries. As far as hollow viscous type injuries, it's not something that's going to be identified on FAST scan, as already mentioned. That's going to be followed up on great serial abdominal exams, and make sure you document those in electronic medical record or your record at your institution. CT scan is good at finding those, but not perfect, and that's why serial abdominal exams still come into play. And even, yes, the less exotic and not so much used anymore peritoneal lavage, especially when you get gross contents back on that lavage, whether it be red blood cell or white blood cell count, or something that's gross contents as far as blood or bile or enteric contents that are coming back on that lavage to help determine if there was an intestinal injury. Not very accurate though. 75 to 90% of those are caught by CT. And what are we seeing on those? Well, we're seeing things that are sensitive. So there's focal bowel wall thickening, mesenteric infiltration. If we see the free air, then okay, we have a good sign of getting to the operating room. But sometimes there's also just subtle findings on intestinal injuries. You might have associated hemorrhage, and you want to control that in the operating room. Of course, the standards of stopping the bleed, controlling contamination by the intestinal injury, and then physiologically stable patient. If they are stable, you can kind of continue on in that definitive care of intestinal injuries. But if not, doing that damage control operation that you see in the bottom right-hand corner to help manage those type of abdominal injuries. Special considerations, things that we like to come across and hopefully manage on a very rare occasion, but are patients that are pregnant at the time. So you're treating two patients at one time. Make sure during your initial assessment of that patient that your pregnant patient is in the left lateral decubitus position, and then understand that they have altered systemic physiology and pulmonary physiology that's associated with pregnancy, and that there's early things that can happen that will disrupt the patient's care as far as an early premature delivery or threatened abortion that offers with placental eruption and significant hemorrhage. Within that pregnancy type physiology, the basic science of that is that they have increased plasma volume. They're already in a hypercoagulable state. They already have an increased cardiac output and oxygen demand. So there's a lot of things that are happening systemically that you need to follow up on and treat throughout that patient's care. Understanding that they even have decreased functional residual capacity, especially when it comes into that third trimester, that they potentially have a difficult airway and need to understand that they're going to have poor reserves. Another special consideration is peritoneal trauma within abdominal trauma. Make sure you have a detailed or standardized way of approaching every patient, and that would include rectal exam and vaginal exam during those potential blunt traumas or even penetrating traumas. If you're finding gross findings from a GU standpoint as far as hematuria, you're going to have to follow up on more specified kind of adjuncts of abdominal trauma care, like cystogram, widely draining those patients if they have intraperitoneal injury, and even laparotomy, like I said, if they have intraperitoneal injury, and then potentially even need for rectal diversion if there's rectal involvement. Kind of in the last few minutes of abdominal care, since we haven't touched on this as far as hemodynamic unstable patients, I want to discuss a little bit on unstable pelvis fractures. A majority of these injuries are due to high energy type blunt trauma. So even though we're dealing with the abdomen, the abdomen pelvis CT scan, right? So we got to consider the pelvis as a box of location as far as hemorrhage. Geriatric trauma patients, Although they might not have a high mechanism, those falls from just standing can be enough to have a low energy impact and cause the same type of fracture patterns. The open book pelvis is kind of the classic one that we're looking for, especially that's found with physical exam, and those have a high mortality associated with them, mainly because they have associated injuries with that open book pelvis. A majority of those injuries are due to high energy trauma, as we already mentioned, but they do have more of a concomitant possibility of unstable pelvis and the fractures that are associated with it. There's hemodynamic instability that's associated with that pelvis fracture, an important physical exam, and one physical exam to identify that pelvis injury, plain radiograph to help discern that, and also CT scan to see what type of mechanism and what type of injury pattern that you have. Again, the FAST scan still proves valuable in a pelvic injury, looking for intraperitoneal fluid, and of course the CTA to look for ongoing hemorrhage. To kind of close down that space in the pelvis, you want to put on a pelvic binder, kind of prevent that life-threatening, or at least close down that space for potential hemorrhage. Have your orthopedic colleagues available for external fixation, and again, the radiology colleagues at the same time for angiography and embolization. But understand is even as a trauma surgeon and general surgeon, if there's interperitoneal hemorrhage associated, especially on CT scan with that pelvis fracture, they're going to have to continue on to operative management like a laparotomy. So in kind of summary, we covered quite a bit for abdominal trauma pretty quickly. But again, you're always going to approach those patients from a direct kind of approach from an algorithmic type of care of A, B's, and C's. Understand that your biggest and most common adjunctive radiographic studies to use have their own indications and their own sensitivity and specificity, speaking specifically of your FAST scan and CT scans. A majority of management of abdominal trauma is really dictated by stopping the bleeding, getting control of your contamination, and stabilizing the patient, especially within a system of physiology and care. Pregnancy, pelvis fractures, and various injury patterns in the perineum often require a specialized assessment and care. So that's it for the abdominal portion, and we'll continue on looking into extremity trauma. So focused review of extremity trauma. Again, we want to always kind of reiterate the importance of initial management from an ABC standpoint. A look at potential vascular injuries in the extremity, orthopedic injuries, and neurological associated injuries, and some special considerations. So in the extremity, again, we're going to have hemorrhagic control, whether it be tourniquets that are provided for hemorrhage control, direct pressure, of course, the final definitive care of operative care. Tourniquets have really come around and really improve survival in combat trauma, and also improve control of hemorrhage and survival in civilian trauma as well. The initial management of the extremity trauma, once we're getting into that secondary survey, radiographic assessment, infection control as far as open fractures, offering antimicrobials and tetanus prophylaxis in a timely fashion, and then trying to prevent any disability and long-term morbidity. Some of that is by important control of vascular injuries, and being able to diagnose this is paramount. Some of those, it just comes on your physical exam, whether it be altered pulses in the extremities or altered ankle brachial index in the extremities. You're going to see things evolving in the extremity as far as a hematoma at a penetrating site, a vascular bruit, or penetrating close proximity injury, things that can cause thrombosis in a vessel, as far as from a penetrating standpoint. Ultimately, though, you're going to look for that altered systolic blood pressure or pulse difference between the extremities, or of course, the ankle brachial index. Things that you're going to use as an adjunct, if the patient's hemodynamically stable, you can produce on the table angiograms to kind of help you concomitantly with an operative approach, or you can call on your interventional colleagues for both a diagnostic aspect of it, of vascular injury in the extremity, or even embolization if it's indicated. Other adjuncts as far as a CTA, CT venogram, even if you're looking for a venous thrombosis, MRI or MRA, I suppose, if there's contraindications to your CT scan, and then just on the table ultrasound, especially in the ED bay, maybe to assist with Doppler and discrepancy on pulses. Again, you're always going to look for that stability of the patient, hemodynamic stability, hypothermia, acidosis, and coagulopathy. This is what's going to help determine the vascular repair versus delay. Get that patient stabilized before you offer definitive repair. Your operative resources, how involved are your operative resources as far as doing a very intricate vascular repair, especially if you have significant soft tissue losses, or severe contamination. Understand that extremity isolated injuries are rare, and there's also associated orthopedic injuries with your vascular injury, as well as other potential life-threatening injuries elsewhere in the body. If the patient's unstable, it's always a potential for delaying repair, and you can use a vascular shunt at that time until the patient's more stable, like mentioned, from a hemodynamic standpoint or other system alterations until the patient's stable enough to have definitive repair. Again, vascular injuries can often be associated with an orthopedic type injury. And just being able to be in the operating room or in the emergency department and, so to speak, be able to speak the verbiage of the orthopedic doctor that you're working with. So again, orthopedic injuries start with that anatomy. So the bone is provided with osteoblasts and osteoclasts that help remodel the extracellular matrix, and that's going to be in response to trauma. The periosteum is going to be a very important, vital component when it comes to healing fractures that are associated with extremity trauma. And then understanding the cartilaginous containments and the attachments are really less vascularized and really require a longer time of healing when it comes to extremity trauma. When it comes to understanding the kind of fracture description with orthopedic injuries, there's an anatomic location, a fracture pattern, displacement, and of course, open or closed. The anatomic location is articular or metaphyseal or diaphyseal type injuries, as well as involvement in growth plates in pediatrics. The fracture pattern, that's going to be a little bit more detailed. So is it a transverse pattern, a spiral pattern, oblique, comminuted, or even segmental, as far as the things that are involved, seen in that picture off to the right. The amount of displacement, for example, looking at letter D in the bottom right-hand corner versus letter B, that's going to be important to also dictate and kind of understand when you have to align and how quickly you have to get that patient out of discomfort and pain. Again, so it's often from fragments that are shifted in relation to one or the other. You can see the fragments and the more involvement on letter C, the fracture there in the distal tibia, if there's translation. And in that particular pattern, letter C, there's anterior angulation that you want to mention. Of course, as the bone has ongoing shortening involvement or rotation involvement as well. The one that's kind of more provided as far as if the fracture is associated with an open or closed technique or injury, and that's really if it's exposed to the external environment. So again, orthopedic injuries from a fracture standpoint, is it open or closed? Really the idea is to stabilize and monitor that patient, make sure you get infection under control, and really try to reduce that long-term outcomes. There's a lot of different ways to grade the fractures. The most common one is the Gostilio-Anderson system, and this allows not just for much interoperative delineation of the type of open fracture, but it really dictates the type of antimicrobials that we're using and the long-term effects of the antimicrobials. The orthopedic injury, again, you're going to stabilize that patient, splint, cast, traction, whatever you need to get that patient's bony injury under better control, even if it requires external fixation or internal fixation as depicted in the two pictures off to the right. Often with vascular and orthopedic injuries, you often have a concomitant neurological injury. Brachial plexus is probably the most feared one, and this is common after falling from a tree or standing on a ladder. But again, a lot of the neurological injuries that are associated with upper extremities, very rare. So 3 to 5% of upper extremity injuries have a peripheral nerve injury. Motor vehicle accident is probably the most common that causes them. Overall, long-term care from upper extremity injury, if they have a concomitant or an associated neurological injury, just increases their length of stay and longer rehab times. Very similar kind of statistics when it comes to lower extremity neurological involvement, although the perineal nerve is the most frequently encountered, and most of those are from car accidents or motorcycle accidents, which can have a frequent cause of neurological injury association. Usually those are presenting in kind of a detailed history and physical exam, often requires extensive imaging and exotic testing like electromyography. Surgical therapy can offer nerve decompression, nerve repair, and nerve grafting, as you might see in the right upper quadrant picture there. Kind of special considerations when it comes to extremity trauma. Understand that there's aspects we need to be mindful of as far as a crush injury, hematoma, any kind of prolonged vascular occlusion, tight casting, or IV extravasation. All these lend itself to the feared kind of compartment syndrome. Compartment syndrome tends to be a clinical diagnosis and tends to have more risk if you have ischemic involvement greater than 6 hours, definitely more involvement when it's below the knee, sometimes at the forearm, And again, the mechanism often will dictate if you're at higher risk for compartment syndrome as well. Again, even the aspect of open versus closed fractures can dictate the higher risk of compartment syndrome. How is it identified? Well, classically by the 5 Ps: pulse, pallor, pain, perfusion, and paresthesias. Compartment syndrome, you can also go into more detailed testing when you have intercompartment pressures that are greater than 30. That often warrants immediate fasciotomy, but hopefully you've caught it clinically before you get on to more detailed and compartment measures. The actual compartment releases are usually done in the lower extremity by a 2-incision technique, and that releases all 4 compartments. And feel free to go back and review these slides to kind of see how this technique is done on reviewing and understanding the release of the lateral incision and what's involved in the medial incision and compartments released. This is a little bit more detailed version of the lateral one that's mentioned, with going over the anterior and lateral compartments. And again, the more medial aspect when you tackle the superficial and deep compartments. Again, a lot of these compartment syndrome, there's postoperative monitoring, concern for rhabdomyolysis, tissue necrosis, any infection and needed debridement that's ongoing, and of course the concern for loss of limb. Sometimes the loss of limb is often dictated by how severe the injury is. So salvage versus amputation considerations, there's significant neurological injury, massive crush injury, failed revascularization, and timing. Is there a lot of muscular injury or necrosis? Probably the one thing that dictates a lot of salvaging of the extremity is a mangled extremity. And of course, like most injuries, we've kind of come up with a score to help with this. And the score is the MES score, and that ranges anywhere from 2 to 4. Anything greater than 4 tends to be considered, quote, a mangled extremity. When there's severe loss of tissue, the duration of ischemia is severe, the level of the patient's shock and ongoing systemic physiology is poor, and unfortunately, how the patient's age kind of fits into all of this. So these are kind of special considerations when it's considered a mangled extremity, and things that you have to monitor and care for in a very definitive tertiary type care or high level trauma center. So in summary, a very quick review of extremity trauma. That's one of the most common injuries that's cared for in the emergency department. Vascular trauma, often associated with orthopedic injury and even neurological injury, requires a very thorough assessment, hemorrhagic control, and determination as if you can salvage that limb or not. Some of that's just dictated on the stability of the patient and the overall physiology. Orthopedic trauma often relies on just stabilizing and definitive care. And hopefully there's no ongoing neurological extremity involvement, and that can help you salvage that patient's limb. The one big factor to look out for as far as complications, things like compartment syndrome and mangled extremity infection control are paramount in requiring a very specialized care and ongoing management. These patients require extensive rehab and ongoing prosthetic type of care if your institution can offer it. Again, so I'd like to thank your attention for the last hour. I'm glad that we were able to cover thoracic, abdominal, extremity trauma. Feel free to go back and review the slides on your own time. Again, I'm Dr. Tony Capizani, and I appreciate your attention today. Thanks.